Good evening, everyone. I hope everybody can hear me okay. We always have a little bit of a challenge with the Zoom technology, at least I do. But in any event, I really would like to welcome everybody and thank you all for being here this evening and taking time out of your personal schedule to join us for what I think will be a very interesting and insightful program. And hopefully it'll be informative for you and you'll learn a little bit more about our center and our program. And by way of introduction, my name is Dr. Jeff Lancet. I am the chair of the Department of Malignant Hematology here at Moffitt Cancer Center. And I have just the unbelievable privilege of working at what I consider the greatest cancer center in the world with the greatest clinicians and researchers in the world who are doing some of the most amazing and breakthrough types of clinical care and research that you'll find anywhere. So I'm very excited about being here tonight and being able to introduce you to some really amazing talent that I think you'll learn a lot from. So before we begin, I just need to inform you that the content tonight is not intended to be medical advice, and you should make sure you consult with your own personal physician if you have questions. Don't rely on this information for immediate or urgent medical needs. And if you think you have a medical emergency, call your physician or go to the nearest ER or call 911 immediately. Never disregard professional medical advice or delay seeking care because of information being presented on this or really any presentation or webinar. Before I introduce the speakers, I want to remind you that after we hear from all the speakers this evening, we're going to give everybody an opportunity to ask questions in what I hope will be a very interactive QA panel. And we'll have several experts on the line to help answer some of your questions. And if you look at the bottom of your screen, you should see a Q&A box that you can open and use to type in your specific questions that we'll all see. And then I'll direct those questions to the most appropriate person. So with that bit of introduction, I would like to start out by introducing a short video. This is what I think is a very inspirational video that features a couple of very generous benefactors to our center who are helping to support the brand new myeloma, Pentecost Myeloma Research Center here at Moffitt, which you'll hear about shortly. But the Pentecosts are in this video and they'll share with you their experience and really sort of outline what the mission of the center is all about. So let's take a look at the video. Thank you.
I'm Mark Pentecost, CEO of It Works Global. You know, we've been very blessed. I was a school teacher, basketball coach that went into business, and we've been very successful. I think we have the responsibility to use that success in areas that we can make a difference. It takes us all to find a cure for cancer. In March of 2016, I was diagnosed with multiple myeloma. I had a dear friend that he just takes things and runs. So he looked up the top 5 doctors in the world and said, we're getting you on the phone with each of them. And I just realized during that period, I said to my wife, I said, you know, Cindy, we had the means and I appreciate that. But we flew up to New York, we went to Boston, we went out to Houston, but the hidden gem is right in my backyard, and that was Moffitt. Moffitt is doing work that is improving patient outcomes. I was getting cutting edge treatments. They took care of you not just as, here's a person and they have cancer, but this is a real person with thoughts, family, friends, and going through this journey. They were able to really holistically make me feel good about the treatments I was getting. They spent the time with me. They spent the extra time when I was struggling. And that's why I chose Moffitt. I'm doing this to help others, whether they're just starting this journey or someone that's been in it for a while that just needs some encouragement to say, we'll get over this. We're going to work together. And then also to bring awareness so that we can find cures. I would not use the word hope. We are going to find the cure for multiple myeloma. That's what we're going to do. Resources may be talent, money, experience, whatever it takes, that we're going to get this done. And so it's not a hope, it's we're going to do this. I guess I hadn't really thought about your support system until you're sick. And Cindy was there. She's been every meeting, driving me when I was sick and couldn't drive. She's the one driving. And yeah, the whole support group is so important.
My family has faced cancer before, and some has been successful outcomes and some has not. Regardless, the journey has always been one of the worst things that a person can go through, and their families. There's already so much going on in your mind, and then to hear one doctor tell you this is the way you should go, and another one that's an expert in that same field tell you it's a different way, to 5 or more doctors, it is beyond confusing, and that is not the time you need confusion. My hope for the Pentecost Family Myeloma Research Center is that all of the research will eventually help people find the treatment they need to have the best possible outcome of healing and cure. My faith is strong, and so I just believe that one day at a time, we'll handle whatever comes, whether it's good or bad, and in our case, it was a good outcome.
I like to watch movies, and so you're always thinking you're the lead actor, whether it's a Western or what, John Wayne, you're courageous, you'll save the day. But that word takes a different meaning on when you're in the journey. I think courageous is getting up every day ready to battle. And courageous is when you get knocked down, you get back up and you get back in the fight. That's courage.
So with that really beautiful and moving introduction, which I think exemplifies what we try to do every day here at Moffitt, we'll go ahead and get started with our program tonight. And first on the docket, I would like to introduce Dr. Rachid Baz. And many of you may know him who are on the line tonight. Dr. Baz is a senior member and professor here at the Moffitt Cancer Center in the Department of Malignant Hematology. He is also the section head for multiple myeloma and a renowned national and international clinical expert and clinical trialist, discovering all sorts of novel therapies in multiple myeloma over the years. And he's gracious enough to be with us tonight to give us an overview of the multiple myeloma program and to discuss some of the very exciting clinical research and translational research developments. So Rachid, welcome and take it away.
All right, thank you, Jeff, and good evening, everybody. Mark and Cindy actually challenged us, to find a cure for myeloma. And we have a strong myeloma program. We have a critical mass of, clinical researcher, basic scientists, and, we were one of the larger program in terms of, patient volume. If you think about multiple myeloma, a lot of you may not know, but is a condition we don't think about it as a condition we commonly cure. We had to think about it and how are we going to approach this? How we get to cure multiple myeloma? So we got our heads together and we kind of came up with the major pillars of the things we need to do that is going to enable us to cure multiple myeloma. And I don't know if I can have the next slide. Basically, it's going to outline a little bit the Pentecost Family Myeloma Research Center, because that's what Mark and Cindy are going to enable us to do to address multiple myeloma in a multitude of different ways. I don't see the slides, but advancing. But nevertheless, I can talk about it without the slide. The point here, here we go. The point here is that the first part of it is that we know that about 5% of the population over the age of 40 have a precursor condition to multiple myeloma. We call that monoclonal gammopathy of undetermined significance. Most of those patients who have monoclonal gammopathy of undetermined significance, or MGUS, most of those patients will never develop myeloma, but there's a subset of them which over time slowly may develop myeloma. So first we need to understand the biology of MGUS and precursor states, and then figure out who are those patients at risk for the development of myeloma, and can we intervene early? Because possibly by intervening at a very earlier point in the patients who are at risk to develop multiple myeloma, perhaps that would be, our greatest chance to cure it. There's been a lot of advances in drug developments, novel agents being developed. A lot of new drugs are approved almost, every year for multiple myeloma. There's several approvals that we expect to see this year. There were approvals last year. But despite those, we kind of, are able to incrementally improve the outcomes. But I think if we invest in, finding novel targets and continuing the novel agent development, we may be to a state where we have, more therapies or better therapies, more effective therapies that can, help address the disease when it does develop. Immunotherapy now is, it's an integral part of, everything we do, in myeloma and in cancer medicine in general. I think with, advance of cellular immunotherapy, things like CAR T-cell therapy, what, sounded like science fiction a few years ago now is a reality. And, we see unprecedented response rate even in patients who have very advanced disease. So this is good, but if we can harness it in a state where, we can better take advantage of the immune system, I'm sure that that could lead to even better outcomes. And then finally, I think we need to, figure out a way to adapt our treatment. We have, in general, in myeloma, this kind of approach where, everybody gets similar type of therapy. And in reality, everybody's myeloma is different. Every patient's different. Every patient has different goals too. So I think if we're able to, adapt therapy based on response, achieving, for example, MRD negativity, as a goal, then that would kind of get us closer to the cure. And all of this is kind of built upon a platform of personalized medicine. A platform of personalized medicine that has been really the hallmark of everything we're trying to do in myeloma for the past 12, 13, 15 years at Moffitt. And so, the lab of, Dr. Shane has developed assays to try to, not just empirically give treatment with an expected response rate, but, better plan our treatment for each patient, giving the right treatment for the right patient at the right time. And so it's, with this model, multi-pronged approach, that we know we're going to cure myeloma that way. I think if we approach it from multiple angles, I think we get the best chance at it. And the goal is really an ambitious goal, is to cure myeloma in the next 10 years. If you think about what is achievable, we kind of all been through this pandemic for the past few years, and when scientists put their head together, there is a development of a vaccine that many thought was not possible. In reality, it was done in a record amount of time. A vaccine that's fairly effective of protecting people from severe disease. I think if we apply our efforts as a community to multiple myeloma, I think we can make the most imprint and cure it. So that's my bit. We have a lot of efforts, that are along those multi-pronged or pillar approach to, treating the disease or managing it. And that's involving, scientists, clinical trialists, but it's a community effort, nurses, transplant physician, but, also neurosurgeon. Basically it's a multidisciplinary approach to myeloma therapy. So, I'm going to give the podium to the next speaker, I think. But it's going to be a pleasure to interact with you guys tonight. And if you have questions, let us know. We'll try to answer as many questions that come up. Thank you.
Thanks, Rachid. It was great. And definitely be circling back with you in a little while to answer some questions, and congratulations on the development of such an outstanding program and what's going to be really exciting times in the next few years for myeloma patients for sure. Next, I'd like to take a minute to introduce Dr. Javier Pinilla. Dr. Pinilla is a senior member and professor here in the Department of Malignant Hematology. For those of you who may not know, Dr. Pinilla is also a world-renowned expert in chronic lymphocytic leukemia, chronic myeloid leukemia, amongst other diseases, and he has really developed a keen interest in the translational components of many of these B-cell malignancies, leading to some novel therapeutic developments. And finally, he has a strong interest in immunotherapy for lymphomas and leukemias in particular. So he'll be giving us an overview of immunotherapy within the lymphoma program here at Moffitt. So it's all yours, Javier. Thank you.
Thank you, Jeff, and welcome everyone. So I think Jeff already introduced myself. I'm gonna really give you a brief, very little history of my life. So I'm a hematologist trained originally in Spain. And more than 20 years ago, when I was attending there, my dream was coming to the States to do immunotherapy. More than 20 years ago, immunotherapy almost did not exist. No one believed that it's gonna be a true therapy for cancer. So really I started my journey and I show up to this country. And now almost 25 years later, find myself as a head of the amazing lymphoma program with a very, very talented, really doctors who really all of them are really dedicated to try to treat and hopefully cure lymphoma many times through immunotherapy. So here you see this slide that was a breakthrough through the year in one of the most really important journals that we have in the medical literature, science. So the next slide represents what really, really simplistic way to see this condition, please. What is immunotherapy in lymphoma? Well, we realized, and after many years studying this, we realized that our immune system can kill lymphoma, can cancer. Obviously, this is very tricky in a condition of lymphoma because you may know the lymphoma is a disease comes from the immune system itself. So we try to attack our own immune system with our own immune system. So the next slide, you're going to see that classically, you can really perform that in many ways. And the reason why I came to this country was to initially I developed cancer vaccine, something that, well, people still don't believe, although I believe that one day will be a reality. Rachid was very nicely really discussed the fact that obviously with the new advances in vaccines, this is also going to translate to cancer vaccines. But the thing that really intrigued me and excited me the most was the issue of cell therapies. Cell therapies that pretty much is use our immune system to attack our own really cells and kill them and hopefully cure them. So the new slide, you will see that this is a very simplistic approach. I will see, right? We get cells, we put it back and we kill them, right? But if you really think about the complexity of our immune system, and the next slide will give you some hint of that, you will see that there is multiple cells involved in these aspects. And there is our duty to try to understand in the lab and applying this knowledge to clinical trials to see how we're going to really improve the cells that they really need to perform this killing of the tumor cells, and how we can improve the health of these cells that sometimes are defective by nature. So obviously, over the last years, and the next slide is going to really also point out this fact, we have a plethora of really immunotherapeutic intervention for lymphomas. CLL, by the way, is one form of low-grade lymphoma, so that's the reason that you're going to really see my comments of that. But here, and it's very complex slide, you will see that it's multiple medications. Many of them, and most of them, really can really work through the immune system. And it's the classical monoclonal antibodies that they would really describe almost 30 years ago. And there was really, really a huge impact in the treatment of our patient with lymphoma. But now we have many other things. But the more important thing that we have realized is something that we've been trying to translate in our laboratory, is that many of the medication, these famous target drugs that really go through a certain pathway, certain molecules and block them, also has a very important role on how they manipulate the immune system and how they make cells better, so they can also contribute to attack lymphomas in general. So this is an example, and obviously in the next slide, I'm going to really briefly introduce one of the projects, philanthropic projects, that is being funded by one of our donors. And the goal is to improve T-cell therapies for chronic lymphocytic leukemia. And when I say that, is obviously we're going to see in a second that we've been very successful with CAR T-cell in lymphomas, although we still have a way to go. But there is no doubt that in this sense, in CLL specifically, cells are extremely defective. And is one of the reasons why our patients with CLL suffer for infections and secondary cancers. So it's like an intrinsic defect on the immune system that we need to really better understand, so we can really use those cells to really attack the lymphoma, in this case, the chronic leukemia, and try to cure this condition. This is one example, and obviously we try to really understand this from the point of view of using these medications that are approved to treat these cancers, and using in the culture, or really in our patient, improve the ability of these T cells, as you see in this really scheme, to kill those cancer cells. This is an example. Obviously, we have many others. The next one is another that Dr. Chavez, a leader in CAR T-cell therapies, I would say in the world, is one of the doctors who has performed the most procedure in this setting, obviously with our colleagues in the department and Dr. Locke also. But in the next project, it's another project that is just in the beginning. We try to understand, obviously, why patients after CAR T, they may have bad outcomes, why may really do not really have such a great success. And this project is something that is starting very, very soon in our lab, and as well, we hope to translate in the clinic. And this in this case, obviously, and you're going to see in the next slides, we really check the origin of the current CAR T-cell therapies. They are very, very popular and also FDA approved. And as mentioned, they are not really the last, they work very well, but not in all patients. So in the next slide, you're briefly going to see that there's many of them approved, and obviously in modular lymphomas, diffuse large lymphomas, follicular lymphoma, mantle cell lymphoma, acute lymphoblastic leukemia, as well, multiple myeloma. So that's maybe the difference with multiple myeloma. We have multitude of different subtypes, and we try to understand how these cells and how these T cells work in each of them. So just to finalize, I will say that the project that Dr. Chavez and our group has started is to understand how we can resurrect the T cells after failing CAR T therapies in lymphomas. So we now, unfortunately, not every patient can benefit. They can benefit sometimes transiently, but at the end of the day, we try to really get those cells from those patients and try to really resurrect them, so we can really use them again to really kill the residual cancer that they are not being initially eradicated. So as you can see here, one of my dreams that I was a young doctor in Spain start to really become a reality, or at least I'm really very honored to really be heading this program and try to really become the cure of lymphoma a reality, as we do in our department. Thank you very much.
So thanks very much, Javier, for a nice overview and highlighting some of the really exciting stuff going on with novel immunotherapy and cellular therapy approaches in lymphoma. So we'll definitely be getting questions about that. And then lastly, but not least, I'd like to introduce Dr. Rami Komrokji, who is also a senior member and professor here in the Department of Malignant Hematology. Rami has been here now for, I think, close to 13 years, maybe 14, I don't remember, almost as long as I've been here. And he's also the the vice chair of the Department of Malignant Hematology. And we work closely together to really advance the causes of our patients within this department. Rami has a world-renowned expertise in the fields of myelodysplastic syndrome and acute myeloid leukemia. He has published countless trials in this particular disease field. And as one of the leaders in the field, he'll be giving us an overview of some of the exciting clinical research programs going on within the field of myeloid malignancies. So thanks, Rami.
Thank you, Jeff. And thank you, everybody. And it's an honor to be here. So the myeloid section here at Moffitt had really three main programs: the myelodysplastic syndrome program, the acute myeloid leukemia program, and the myeloproliferative neoplasm program, with a lot of interaction. We have several clinical investigators, including myself and Dr. Lancet, who would see patients in clinic and conduct trials, physician scientists. We are privileged by a lot of cores that support our mission, such as our colleagues in the stem cell transplant, hematopathology, supportive services, and the research unit. Next, please. Now, the myeloid section at Moffitt is one of the largest programs in the country, serving patients, actually internationally, in certain diseases, for example, like myelodysplastic syndromes. I think we see the largest number worldwide in terms of new patients. At any point, we run somewhere around 50 plus clinical trials and have a large number of patients enrolled to clinical trials. Over the years, as Jeff mentioned, since we've joined here, we built the largest single institution databases in myeloid diseases. So all the patients that come here, we capture their information, how did they present, what were the disease characteristics, every treatment they got, and the outcomes. So in MDS, for example, we have a database of 5,000 patients that we've studied and published extensively from, as well as in AML as well. We have almost 5,000 patients. We are part also of the Total Cancer Care Program, where we can leverage this clinical database with samples from the patients. Total Cancer Program is a program at Moffitt where allows us to follow the patient through their journey. So we take some leftover samples over years and we correlate that with clinical outcomes. We develop our own clinical pathways, how to unify the treatment within the department. And a lot of us are members of the National Cancer Center guidelines that basically dictate the treatment guidelines for community physicians. And obviously, we have physician scientists in the department that conduct translational science. For example, Dr. Eric Padron at Moffitt is always excited about what we call PDX models, patient-derived xenografts, where we take samples from patients and graft them in the mice and mirror image the disease. And in many trials, when we are trying those medications in clinical trial, we are also testing them in the lab and to see the correlation. So also, they discover and identify targets for us to design our clinical trials accordingly. Next, please. Now, those are some examples of drugs that were developed at Moffitt that led to the FDA approval. Years ago, lenalidomide was developed here, or we led the clinical trials that's approved for a subset of patients with myelodysplastic syndrome. Dr. Lancet led the development of a drug called CPX-351 from phase 1 till the approval. And this is a drug now used as a form of intensive chemotherapy for patients with acute myeloid leukemia that comes from MDS, or we call them secondary or therapy-related AML. I co-led the development of luspatercept. This is the first drug approved for MDS in 10 years. And we also conducted, original phase 1, phase 2 trials with a drug called pacritinib for myelofibrosis that's currently in front of the FDA for approval, which hopefully will be in the coming few weeks. Next, please. Now, moving forward, obviously, similar to what Dr. Baz and Pinilla mentioned, we are moving into themes or directions one of them is obviously personalized and targeted therapy. As we became more sophisticated studying those diseases, we know that not all the patients are the same. In every patient, there are certain abnormalities, whether it's at the chromosome level or the gene level, that really drive the disease. And treating all the patients the same is really not going to be the way for the personalized and future way of treating myeloid diseases. So I listed here some name of the genes that we really are now kind of going after with targeted therapies. P53 is a commonly, poor prognostic abnormality. This is a mishappening that happen in complex diseases, historically associated with very poor outcome. And Dr. Salman in the myeloid section focuses really most of his research in this area. We've led trials with drugs that can modulate this abnormal protein to restore its function with a drug called APR-246. He's leading trials with a drug called magrolimab that I'll talk about in a second under immune therapy, also particularly showing promising activity in this P53. FLT3 is an abnormality in acute myeloid leukemia that historically was associated also with poor outcome. There are some drugs approved for this, but we are also leading the newer generation of those targeted therapies. Dr. Kendra Sweet is leading accrual on one of those and bringing other studies as investigator-initiated studies, particularly focusing on those patients and so forth with the list here. Those are all targets that we currently have or activating trials to target those mutations. Next, please. Now, as again, in myeloma and lymphoma, we are trying also to take advantage of the immune therapy in myeloid diseases. CD47, for example, is a receptor or antenna on cells. It's known as the "don't eat me" signal. So when this is expressed, it prevents macrophages from engulfing the cells. And it turns out that in leukemia and MDS, those receptors or antennas are overexpressed. So we have now antibodies that block them that will allow the immune system to kill the MDS or leukemia. We've led the development of this through the phase 1, phase 2, and now it's in phase 3. It had shown almost doubling of the response rates that are historical for a drug called azacitidine in MDS. And it seems to be agonistic of the mutations, so it may overcome bad mutations like the P53. CD123 is another, receptor or antenna that's expressed in leukemia stem cells, and we have several trials targeting that, whether it's a monoclonal antibody or an antibody that is loaded with a chemotherapy that specifically will kill those cells, or part of the CAR T. And similarly, other targets here. We are leading, several clinical trials with CAR T for myeloid diseases. As you heard from Dr. Pinia, now CAR T is approved for lymphoma. It's still in the early stages of development in myeloid diseases. Again, Dr. Salman and Bejanayan are leading those trials. We have 3 trials, and with one of them that showed the most early promising results with the CAR T for myeloid diseases. Next, please. And again, similar to what's thought, done in the myeloma, we are moving also to this principle of prevention and cure. So we are establishing the first program of what we call CHIP, or CCUS clinic. CHIP is abbreviation, refers to clonal hematopoiesis of indeterminate potential. It turns out that this is the first step to develop many of those diseases, that as we get a mutation in one of the genes in the blood, we carry those somatic mutations. For example, if we sequence 100 people walking in the street now above age of 70 with sophisticated testing that have no abnormality, around 20% of them will have already a mishappening we can identify. And those patients are at risk of developing myeloid diseases, but other heme malignancies. And interestingly, other diseases such as atherosclerosis. So, and our group, found out that those patients, if they received chemotherapy for other diseases, they are at several folds higher risk of developing therapy-related AML, damage from the chemo itself. So we're establishing program now to focus on that, with the hope of earlier intervention studies that first we understand the risk, how those patients develop the disease, and maybe bringing, anti-inflammatory medications, targeted therapies to prevent those to progress to a frank, acute myeloid leukemia or myelodysplastic syndrome. Next, please. And finally, some of our faculty are really interested in the quality of life and healthcare disparities, an area usually doesn't get much of clinical trials focus. So our group had been trying to look at racial and gender disparities in MDS, AML, looking at difference in outcome, access to healthcare, but also at the molecular profile and phenotype of the disease, looking at outcomes in older patients, and developing tools to assess quality of life, because really in clinical trials, we've not had objective tools to reflect on the quality of life and the effect of the treatments for those patients. So part of our group focuses on that, and we have like NIH-funded research examining quality of life tools in patients with myeloid diseases. Next. I think that's about it. This is the team, and I really appreciate the opportunity to tell you a little bit about ourselves, and we'll be happy to take questions at the end. Thank you.
Thanks. Thanks, Rami, for that really nice overview of the section and some of the great work that's going on within the myeloid disease states, and not just necessarily the treatment of the cancer itself, but as you alluded to in the last slide, opportunities to really focus on quality of life and the patient experience going through the treatment, which I think is very, very important and goes hand in hand with the success of the therapy itself. So thanks for highlighting that. And we're going to move on now to the Q&A session. But before we do that, I'd like to just take a minute and introduce a few of our panelists here. And these panelists are also world-renowned experts, as a lot of people are here at Moffitt in the field. And the first one is Dr. Nelly Bajanyan. Nelly is an associate member and professor in the, mess this up, Nelly, I apologize because your department name is so complicated, but it's the Department of Blood and Marrow Transplant and Cellular Immunotherapy. I think I got that right. But Nelly has a strong interest in the myeloid diseases and stem cell transplant and other cellular therapy approaches, including CAR T-cell therapies for the myeloid diseases. So welcome, Nelly, and I'm sure there'll be some questions for you. We also have Dr. Julio Chavez on the line, and Julio is also an associate member and professor here at the Moffitt Cancer Center in the Department of Malignant Hematology, and is an expert in the field of B-cell lymphomas, in particular large cell lymphoma. And as Javier mentioned earlier, Julio has probably the single largest experience in CAR T therapy in the world. And his efforts have led to some major publications that have paved the way for development and approval of CAR T therapies for lymphomas. So Julio is joining us as well as a panelist. And finally, we have Dr. Ken Shane. Dr. Shane is also an associate member and professor in the Department of Malignant Hematology here. He is a physician scientist who does translational research in the field of multiple myeloma and is one of the co-leaders of the Pentecost Comprehensive Myeloma, Pentecost Family Myeloma Comprehensive Research Program here at Moffitt. And Ken has a lot of expertise in the area of translational research in myeloma and has developed a really interesting model for testing drug sensitivity in multiple myeloma to help predict which types of drugs may work in different types of patients. So Ken, welcome to the program, and it's great to have you here, and I'm sure there'll be some questions thrown your way. And then finally, I wanted just to take a moment to introduce Tyler Wilson. If you don't know him, Tyler's been a tremendous partner for all of us in the department. He works with the Moffitt Foundation, and he partners with the Malignant Hematology Program to really ensure that we receive the research dollars that we need through philanthropy to help get clinical research off the ground and to really help pave the way for important advances in cancer treatment. So if you'd like to learn more about how you can help, if you're interested, please feel free to reach out to Tyler at any time, either during or after this meeting, and I'm sure he'll make himself available for questions as well. So thank you so much, Tyler. So with that, we'll go on to the question and answer session, and I will ask each of the panelists to try to be brief because we're going to have a lot of questions, and I really don't want us to get hung up too long on any one individual question. So let's start out here, and we had a few questions that had come in prior to the session that I think we can touch on. So let me start with Julio, and this is a lymphoma question. What are, in your opinion, what are some of the biggest obstacles to improving CAR T therapy in lymphoma?
CAR T cell therapy has, revolutionized the treatment of lymphomas and other, and it's actually changing the landscape of treatment of other malignancies. And my focus is lymphomas, and there are challenges, and there are several challenges during the journey of patients during CAR T cell therapy. The first thing is, how to get the patients there. And that's the first thing, insurance approval, having early referrals is important for us to kind of work up patients and get them safely and faster to be treated. Obviously, there are some other challenges, such as, some patients actually may get too sick to do CAR T cell therapy, like, with large masses or bigger or symptomatic patients. So those patients tend to have more complications during the CAR T cell therapy journey. And the third challenge I see is on patients who relapse. So what can we do at this time is still under investigation. So we're kind of understanding which patients don't respond as good as to CAR T as others. So, but probably the best thing that we can do at this time is to have early access, early referrals. So the healthier the patient is, the less advanced disease that the patient have, we will see better outcomes actually. So if you have a patient, or you have somebody who is undergoing chemotherapy for lymphomas, so especially for large cell lymphoma, and we're not seeing a good response, or we're seeing a slow response, then it's important to consider CAR T as a potential option. So we can kind of assess the patient and see whether it can fit in treatment earlier.
Thank you so much. Let's move on to another question. And this question will be for Dr. Bajanian. The question is, what does the future hold for CAR T therapy in MDS patients?
Thank you. As actually Dr. Komrokji mentioned, we have currently few trials available for CAR T therapy. We're still behind of lymphoma, multiple myeloma, and other acute lymphocytic leukemia type of malignancies. And the reason being, it has been harder to find target on cells of these myeloid cells that they are not expressed on normal stem cells. However, I think we are getting better in terms of therapy. So we have CAR T trial available for AML, which is acute myeloid leukemia, and myelodysplastic syndrome as well. So hopefully we will find cure potential for relapsed patients as well with MDS and AML in the future. We see some good responses, but it is still early in this treatment phase.
Thank you. No, I just would reemphasize that Dr. Bajanian and Dr. Solomon here at Moffitt are leading some cutting edge trials, some of the very first CAR T trials ever run in AML and MDS in the country. So that's really still an area under development, but in which we have a lot of trials going on right here at Moffitt. So definitely an exciting area. Another question, let me, of course, we're going to get to some COVID questions. So why don't we start with this one for Dr. Pinilla. Are there any COVID vaccines or treatments or antivirals for immunocompromised patients? And I guess maybe you could just briefly talk about if I'm reading the question correctly, the efficacy of vaccines in immunocompromised patients and how that might affect, how we manage these types of situations.
For sure, is one of the hottest topics and one of the largest amount of questions that we have in our practice on a daily basis. To start with, immunosuppressed patients is a very, very general concept, but depends what kind of therapy, depends what type of condition you have. will depend on how well you may react or may mount an immune response to the vaccines. We know that the patients who really have worse immune response are the patients many times in the hematological disorders, in the lymphoid malignancies, who are treated with specific therapies that abrogate this B cell response, that they are really the cells who really can mount this immune response. So the answer is after being said that, so we have two options, right? When the patient has test positive for the COVID, we have today interventions in the way of monoclonal antibodies, as well antiretrovirals that can be effective in prevent the severity of the condition. Is something that we are implemented in the clinic here and other centers across the state. And more recently, there is a approval of a monoclonal antibody that is going to be given to patients to really avoid to have this infection in the future. It still is in the very beginning. We try to select, at least in our institution, the patient who has more immunosuppression, who are really being therapies who really completely abrogate the immune system. But I think the future is very promising, as Dr. Rachid Baz said. There's a lot of brains put in getting the best therapies for these the now bad infection that is unfortunately affect many times of our hematology patients. So I think we really have these tools, and I think we're going to keep having more and more to protect our patients from these infections.
Thank you. I'm sure we'll have some more questions about COVID, but let me go to Dr. Shane for a moment. There was a question about whether there are any specialized assays for multiple myeloma that might benefit a patient who is stable and in remission on maintenance therapy, I believe is the question. So I guess
great question.
Monitoring for low-level disease burden, I guess.
Yeah, so I mean, we've talked about a number of ways to think about it. There's something called minimal residual disease testing that is becoming enrolled and integrated into our myeloma therapies and kind of algorithms today. And it's a way to measure disease far below what we can typically with blood tests that we use or urine tests or imaging, but have to take into account with all those things. And right now we're trying to figure out is if we find a patient who is now MRD negative, we can't measure disease at all. Usually that means less than 1 in a million cells in their marrow are myeloma cells, which is a really good thing. We're now learning using trials, et cetera, to try to figure out if this is a time we should think about stopping therapy for some individuals versus not. These are all things we want to do, but they're in the midst of investigation. So are there specialized tools? Yes. One is, again, MRD testing or minimal residual disease testing. It's something we all think about. It does require a bone marrow biopsy at this time. We hope someday we can do it just by using your blood. But again, these are all kind of future endeavors. But right now, yes, there is. Two, we don't quite work on it in terms of yes or no yet until we get some better answers. But that would be my quick answer to that. I can have a much longer one if you want, but I figure I'll take it quick.
We'll take the short version this time. Trying to distribute the questions amongst the panelists as evenly as I can, because there's some great questions coming in, but we want to hear from everybody. This is for Dr. Baz. Are there any novel therapies available or currently being developed to prevent MGUS from becoming multiple myeloma? Great question.
So there are no approved therapy currently. However, there are therapies in development, and actually, we just looked at early treatment for patients who have high-risk smoldering myeloma. So if you kind of look at the spectrum of precursor condition, there is MGUS, smoldering myeloma, and then active myeloma. And for high-risk smoldering myeloma, we participated in a trial by the International Myeloma Foundation. I believe we were the lead accruing site, and it to give an aggressive therapy with the goal of curing smoldering myeloma. But there is other therapies looking at immunologic maneuvers that are being developed. It's too early to say whether how effective they are, and there will be. But this is definitely an area that we want to do more in terms of preventing disease. I think that this is an opportunity to intervene at a time where the patient is, healthy, they're not encumbered by the symptoms of the disease, by the damage the conditions can affect the body. So, so definitely more to come on that area. Right now, no approved therapy, but I'm confident it will be in the future.
Perfect, thank you. For Dr. Komrokji, a general question on maybe the latest on research for MDS patients. So maybe just a brief discussion of a couple of the most exciting trials that you think are going on in MDS currently.
Sure. So I think part of the research is really had also been focused on the better risk stratification and assessment of the disease. So now we have much better tools to understand the risk of the disease. Our group actually had been involved in many of those, and also using things like artificial intelligence to develop models. In terms of therapeutics, we think of MDS as a lower risk, where our goal is to improve blood counts, prevent blood transfusions. So there are several trials going there. We are co-leading a drug called Imtellistat in phase 3. That could be the next drug to be approved in MDS, had shown promising activity in early phases. Luspatercept, the drug that I mentioned, we developed here originally, also is like being further explored. The higher risk MDS, where obviously the outcomes, unfortunately, usually are more poor. There are a lot of, there's a focus on almost thinking of this principle of total therapy in MDS. The backbone for treatment for many years had been hypomethylating agents, 2 drugs approved by the FDA, one called azacitidine, decitabine, and considering allogeneic stem cell transplant. So, there are several trials to try to improve the azacitidine or decitabine responses. Our group had been leading several of those. As I alluded earlier, the magrolimab is a drug in phase 3. There is a drug called venetoclax that's approved for AML, and that's also in phase 3 trials. The TIM3 inhibitor that I briefly alluded to, a drug called sabatelumab, also is going into phase 3. So again, hopefully the idea would be improving the response rates. Obviously, we are looking at strategies of maintenance therapy, particularly after transplant. Dr. Bajanian have several trials also here at Moffitt. So we are really thinking of that total therapy. So I would say that at least there are like 4 or 5 drugs in a phase 3, which means that hopefully if those clinical trials are positive, then they will be approved and available for our patients.
Thanks, Rami. And just to reemphasize, it's such a diverse disease, MDS, and there's so many different subtypes and really goals of therapy as well that need to be addressed by a whole host of clinical trials. So I think we've got over a dozen trials for AML and MDS open here at Moffitt. So there's a lot going on based on the diversity of the disease. Let me circle back to Dr. Bajanian. We have an interesting question. As professionals in this area, do you ever envision a world in which transplant could possibly be replaced solely with CAR T and inhibitors after induction and consolidation? And I think that is primarily referring to myeloid leukemias. So maybe you could just touch on that quickly. It's not an easy question, but an important one.
No, I know it's a very interesting question, and it actually comes up very frequently, as a matter of fact. We would love to see that, obviously. I mean, transplant is a difficult procedure. I mean, mortality risk is not minimal. And there are other complications, such as graft versus host disease, that can affect patients and their quality of life. If we find actually this being really a curative option, I mean, the CAR T-cell therapy that targets myeloid malignancies such as AML and myelodysplastic syndrome, that can be a true game changer. But there are other therapy options available to us as well. Like here at Moffitt, many of us actually know here from the panelists that we developed gamma delta T-cell therapy option. These are cells that we have. These are good anti-cancer cells, but number of them are very low, about less than 5%. And we can collect them and use artificial cells to expand them and infuse to patients. This is something that we are exploring as well. Other options are there as well, such as T-cell therapies that are not genetically modified necessarily, but can go after certain antigens on AML and MDS cells that we are exploring as part of clinical trials. I'm hoping that some of these trials will be successful and can replace bone marrow transplantation, but yet to be determined.
Thank you. Yes.
How I would best summarize it at this stage.
Awesome. Thank you. Let's take another COVID question. I'm going to pose this one to Dr. Chavez because it raises some practical issues. Is it or will it be appropriate to take Evusheld monoclonal antibody therapy while being treated for non-Hodgkin's lymphoma with agents such as Revlimid? Or others?
Yeah, exactly. I mean, there's been a lot of questions about the Evusheld, and we were going through try to develop a system to use this antibody on a specific patient. So keep in mind that it's only emergency utilization approval. There's not like a full FDA approval. It showed utility in unvaccinated patients. So we don't know yet in that the specific patient population will work. So the current recommendation is for patients to have the vaccine, and our current approach actually is to have the vaccine, at least the 2 doses and maybe the booster, and then check the antibodies. If the antibodies are not present, there may be a patient that should get the Evusheld. So basically, patients who are on active immunotherapy, they're probably immunosuppressed and they may not be able to develop a good antibody response against COVID. So in that case, what I would say, make sure that patient had vaccination, had immune response, and then if it's still negative, then consider doing the Evusheld.
Perfect. Thank you. It's going to be interesting to see how it pans out as we develop more and more knowledge about COVID and as more variants likely will strike us in the future. I'm going to take the next question myself because I think it applies to the entire group. And I think we have the option of going over a little bit. We're supposed to have a stop at 7 o'clock, so we welcome people to stay on a little bit longer if they're able to. The question is, can you please share how you communicate with and support your patients during their challenging journey? How accessible are the staff and doctors? Please describe holistic care and resources available to your patients. So great question, and something that I think as a group we're challenged with all the time and something we're trying to improve upon. I think it starts with a team approach. So when a patient comes to Moffitt into the Department of Malignant Hematology or the transplant and cellular immunotherapy program, it's not just one person reviewing the case, it's a team of doctors and APPs and nurses that are looking at the case and reviewing it in various forums, including tumor board, to try to come up with the very best plan of action, or to make sure that the diagnosis is correct, and then to come up with the best plan of action. So it's a team approach from the diagnostic and therapeutic standpoint. So there's usually not just one person making the decisions, but a consensus that's based upon evidence and current guidelines and pathways. We try to communicate the best we can, and by doing so, we've launched a team approach so that there's never just a one-to-one interaction between a patient and a provider. So there's a team of providers that are available for the patient, including the primary doctor, one or more advanced practice professionals or APPs, and a clinic nurse. So there are various methods of communication that can take place through those channels that doesn't necessarily need to come directly to the doctor, but can often be answered by the nurse or the APP. We have a very active computerized message center through our electronic health record that also helps facilitate communication without having to pick up the phone. So the message center is very key in that. But I will point out we have challenges, and we definitely need to work on improving communication and being able to answer patients' questions and concerns sooner. And how to juggle that during a very busy clinic day when you're seeing multiple patients remains a challenge. So I welcome patients' input and feedback as to how we can make communication better, because the patients are the ones that are going through it and the ones that are experiencing the ups and downs, and we need to hear about the patient's experience in the communication field. So thank you very much for that question. Let's touch on another question. I'll go to Dr. Shane. Actually, no, Dr. Baz is answering that question already. So let me see if I can touch on another one here. And maybe I will ask Dr. Komrokji to answer this question. Can immunotherapy be of help to someone with MDS or essential thrombocythemia if they happen to be mutation negative? So maybe you can touch on that.
All right, so that's a good question. So obviously, like our only cure for many of the myeloid diseases is allogeneic stem cell transplant, which is form of immunotherapy. And obviously, hopefully the newer therapies will have less side effects and, you know, less toxicity and better responses. In terms particularly for the triple negative diseases, or like for the diseases where there is no abnormality, I think immunotherapy will be important, because in many of those diseases, the immune derangements are main driver for the disease, and we know that, you know, immunotherapy could be important. In lower risk MDS, we use sometimes form of like earlier immunotherapy, like anti-thymocyte globulin with cyclosporin for patients with lower risk that can yield sometimes, you know, remarkable responses. Interestingly, I think in the essential thrombocythemia, many of those patients, majority will have a mutation. And actually, interestingly, for particularly a mutation called calreticulin, we are going to be bringing one of the first mRNA vaccine-based study, because that calreticulin mutation is immunogenic. And Dr. Kirkendall is going to be one of the leads on bringing that mRNA-based vaccine study for that population. So essential thrombocythemia without markers is not a common thing, but we are bringing some of immunotherapy for the calreticulin mutant, which is known to be immunogenic.
Thank you, Rami. Nice answer, short answer to a very comprehensive question. Let me just, there's a couple of questions that overlap here, and I'll just go back to Dr. Pinilla briefly to address them, since he is leading many of our COVID efforts here. Javier, I guess one question is, in vaccinated patients who are currently or recently post-treatment, including, say, autologous transplant, is there a window of time in which people can rejoin group activities and be less isolated? I know it's another tough question, but something we're hearing a lot about.
Well, I think it's a question more for the transplanters, for sure. It's something that we understand that immune recovery after transplant can take a while, sometimes more than a year and a half. So I think it's a matter of make sure that those patients, as transplanted do, make sure that they get really their own vaccinating again, and be in the best way, in the best immune system, shape, to really be able to really rejoin these activities that obviously in the pandemic of COVID is kind of been quite limited. So I think I would say before the COVID, maybe it was an easy question. Now with the COVID, it's getting a little more complicated, and we try to protect as much as we can patients that could be immunocompromised in several ways, including after a transplant.
Yeah, if you just want me to add as a transplanter, Javier, you are absolutely right.
Thank you so much.
Yeah, immune reconstitution, and depends on the transplant type. Obviously, it is easier after autologous transplant than allogeneic transplantation when you get stem cells from a healthy donor that is not your own stem cells. And these patients are on immune suppressive medications for quite some time, some of them for the rest of their life. And immune reconstitution, meaning the recovery of immune cells, comes back to normal only after 2 years of transplant, assuming patients are no longer on immunosuppressive medications. Much better a year later, but it takes about 2 years to get to normal person's immunity. People need to be extremely careful, protect themselves, particularly when they are in early stages, especially if they are on immunosuppressive medications.
Thank you, Nelly. Let me go to Dr. Shane briefly. There's a question about from one of the guests about what I think is intended to be 17p deleted multiple myeloma, and maybe you could comment on briefly on how you approach patients with what would be high risk multiple myeloma. Is that any different than you would approach a more standard type of disease? So the high risk setting.
That's a great question, and one that we always face with all of our patients is what's the best way to take care of patients on an individualized basis or a personalized basis. And I think you've heard Rachid kind of talk at the beginning about the foundation of our entire endeavor is about trying to personalize therapy and make things right for the right patients. And so that's a long introduction to say, when you have high-risk disease, we want to treat you in a very specific way. We want to make sure we give you all the options that are available. And usually it means, from a perspective of myeloma in a transplant eligible individual, we're going to get 3 or 4 drugs today, 4 drugs by upfront, high dose therapy with autologous stem cell transplant as a consolidation. And then typically we're going to be on maintenance, but the maintenance will change as well. And we want to make sure that throughout the course of that, outside of transplant, you're going to be on both an IMiD, so Revlimid or lenalidomide, and we want to maintain a proteasome inhibitor, so Velcade or Kyprolis, depending on what you're on in that relative schema. And that's the way we know best to help kind of overcome that high risk feature. And so what it really means is we understand that the proteasome class can be more effective, or at least overcome some of those high risk features. And so that's how we've built our program. And most myeloma centers around the country will do the same thing. And in fact, it's been validated by a retrospective look at folks at Emory, where they showed that kind of risk adapted therapy really benefits those patients to a great degree. So something we all want to make sure we think about, but it does mean we want to give patients like different therapy because of their high risk status. And generally means being, I'm not going to say more aggressive, but maintaining more therapy for longer periods of time and specific therapies. Again, the proteasome inhibitor class and the IMiD class where tolerated. But a great question.
Thanks, Ken. That's a great answer. I'm going to put, I think I'm going to put Ken and Javier on the spot a little bit here to answer this question together. It comes from the EVP of our foundation, Maria Muller, which is a great question. Amongst the different types of malignant heme diseases, are there things that researchers can learn from each other's approaches? So as our two key translational physician scientists, wonder if you could comment on what and how you've learned from each other in the field of research.
I can tell you one thing. So Javier's lab and my lab are actually next to each other. So there's a lot of sharing that goes on there. Not that Javier and I know where the labs are, but that's where the labs exist. But no, I mean, it's really critical. I mean, from a basic science perspective, like a translational science, I can tell you we have an entire project built around inhibiting this certain class of kinases. Okay, proteins that signal in a patient's body, a cell that helps keep cells alive. And we're targeting it to kill bad guys, kill myeloma cells. And then, oh, by the way, you know what Javier's doing across the bay is using the same kind of inhibitor, the same class of drugs to modulate the immune system in CLL. So I would argue that's a pretty tight communication and a pretty much shared how we can use the same kind of signaling pathways to target the same family, again, in the same different labs, but doing the same thing, affecting each other's diseases a little differently. So again, that's a basic science, translational science analogy. And I'll kind of let Javier kind of talk more about, actually I can talk for hours about another way we're doing it too, which is again around treating patients and testing drugs in patients as well, where we've developed an assay where we can take cells out of patients, treat them to a whole bunch of drugs at the same time and see what their cells are sensitive to. Hopefully predict how they're going to respond to therapy in real life. And we call that EMMA. And again, with Javier and others, we've been trying to translate that into CLL and other kinds of diseases that he focused on as well. And he's beginning to adapt that as well. So those are two things I would share with you from the kind of translational science perspective and how we can affect each other and learn from each other in those disease states.
I cannot really put it in a better perspective that Ken did, and obviously we working together in the research. Obviously, we work in departments, but at the same time, we learn from each other's going through seminars and really learning how everyone is doing. But and again, this history is almost anecdotal, right? Because sometimes you find by accident some of your colleagues is really working with you, is doing something that could be completely relevant with their research. And that's the reason it's very important, this relation between the investigator as well the clinicians, because the clinicians, we are clinicians too, but also the inspiration of problems sometimes comes from the clinic. We really put our brains to work and find solutions that maybe are in another place, that they are not our lab or in the same institution where other basic scientists are developing drugs that we didn't even hear about that. So I fully agree that obviously the one of the more also easy example that we talk all the time this night is the immunotherapy. I mean, immunotherapy, we have been using across the board, right? Immunotherapy was something that is general, come from cancer, but definitely the fact that we are open now, we start, obviously, lymphoma was pioneer in this development, but myeloma is coming after, acute myeloid leukemia. We are really thinking that it's going to be the next breakthrough, and it's going to be there through multiple areas, CAR T, the gamma T that Nelly was mentioned. So I think the way that we approach the immune system is really something that all of us will learn, because we are really using very similar types of cells coming from different diseases treated with different drugs. So we understand what type of quality these cells are, how we can really get them better, what kind of therapies can affect them, and at the end of the day, really use them to really cure our patients.
Thanks, Javier and Ken. And I would say also on the end of the spectrum that comprises clinical research, we also share in the formulation of ideas, because many disease mechanisms are molecularly based, and it's quite possible that a drug that affects a certain target that is present in more than one disease could be active in more than one disease. So we're starting to see more clinical trials, opening more clinical trials, including investigator-initiated trials that are covering a larger portfolio of diseases than just a very small disease subset. So in the clinical research arena as well, we're exploring more of these types of umbrella therapies that can where one drug could apply to many different types of cancers. So it looks like we've gotten through most of the questions, and either verbally or by typed response. I thanks everybody for staying active on your keyboards and helping to answer some of these great questions. But we are coming up against the quarter past the hour, 15 minutes from where we should have stopped. So I think this might be a good place to end the session and wrap things up. And I just wanted to really thank everybody, all of our guests in the audience who took time out of their schedules to be with us tonight and to hear about some of the exciting things going on at Moffitt, and to ask some really insightful questions that keeps us on our toes and makes us think about things in different ways that might spur us to ask the question about, well, maybe we could use this new drug, or maybe we should study this in a way that we hadn't thought of before. So thank you for all the insightful questions. Thank you to the entire panel tonight for giving us a nice overview of your different sections and the diseases and the work that you're doing, and sharing your expertise with so many people tonight. It's nice to be able to get everybody, not in the same room, but I guess on the same virtual platform, to allow our audience and patients and families to share your knowledge. So thank you for that. Thank you so much to Tyler and to Stacy for organizing this incredible forum, which I think exceeded everybody's expectations. It's really their work that led to this tonight. Tyler and Stacy were on the phone with me quite a bit, harassing me to start to get things done, and finally we put it all together, and it turned out to be a great program. So thank you both for really stepping up, and Patty Murphy as well for your efforts in helping to make this a reality tonight, and hopefully we can continue to do this on a regular basis, and to share our ideas and our programs with you, and to have our patients and families and supporters share their ideas with us, so that we can ultimately formulate the best plans for the best outcomes for our patients. So with that, I think I will close and thank everybody again tonight for joining us, and wish you a great rest of the week and weekend. And please feel free to reach out to any of us with additional questions or concerns, and we'll be happy to keep the conversation going offline. Thank you again. Have a good night.
Thank you, everybody.
Thank you, everyone.